We have a very thin, 3 months old, raised very thin, he's tall, long arms, lengths. His eye lens look like he's locating. There's some evidence of scoliosis, a little bit of curvature. You listen, the kid is hard, mom. This persisted even at 6 months. It was still the same. They couldn't figure out. So they said, "Well, what is going on? 6 months is the same thing, right?" And then a follow up when he's 6 years, it's getting worse, more scoliosis, right? And then he's even taller, too tall. He's tall, he's long. His arms are so long, like he can put it at the back of his head, right? What do you think is going on? Assisted in 6 months, 6 years, and still showing that this is what we call Marfan syndrome, right? And it's a genetic disease, autosomal dominant inheritance. So it's passed on from one generation to another, no matter what. 50% of the kids is going to have it. Okay, now, what complication for this problem syndrome? What do you want to worry about? I can tell you it's a connective tissue disease. So they're going to have problems, aortic valve issue, right? They're going to have heart valve issue. They're going to have some dissection. They're going to have aneurysmal formation of the vessels. They're going to have some prolapse of the valve. So those are the complications that will happen. And then, of course, the eyes, mostly retinal detachment, right? Or lens, which we saw, dislocation. So that's the problem for this kid, right? And therefore, if I wanted to give me, your board will take you there. Teaching, education. What is normal? Give me two teachings. Two teachings. Important teaching. You want to make sure these are kids who is 6 years you know about. It's a female, so but what is the most important teaching that you should be able to give this patient to, in order to save them? So number one, no contact spots, right? What is number two? What is number two? I give you a clue. It's a female. What do you think? No pregnancy. If you want to have babies, do it early as much as possible. So you can't wait until you are in your 40s, you want to have 30s, and if you want to have a baby, I want you to have it quickly. So you should get pregnant and have a baby early in your childhood, not childhood, but early before you are like over 40 years old. So make sure you get them because it become a problem when you get older. Okay. Unfortunately, she became pregnant when she was 21 years old. So 21-year-old, now pregnant. She presents when she's like 26 weeks to the emergency room, right? That's when she presented with that tearing chest pain that will lead into the back. What do you think is going on with this patient? So this is what we call ascending aortic dissection. So that's what she has. She has dissection, right? This is usually due to the intimal tear. That is the inner lining. Give me number one, priority, function. So number one important is to control heart rate and blood pressure. And therefore, what are you going to give this patient? Surgery is not important. If somebody tell you surgery is the most important thing for this problem, it's wrong. Okay, this is wrong. when you have this problem, surgery is going to kill them. Okay. The most important is hemodynamically monitoring. So you want to control heart rate and blood pressure. So that is the most important to prevent the dissection becoming a rupture. So you want to control the heart rate and the blood pressure with esmolol. Esmolol is the same thing as labetalol. So you want to give them labetalol or esmolol. This will control the heart rate and the blood pressure. That is number one. That is your priority. If somebody tells you surgery, it's wrong. Okay, this is your priority. Patient does not need surgery right away. We want to make sure they're getting heart rate control and blood pressure is controlled. So your priority is a beta blocker, IV beta blocker. This will control. This is your priority. What is your priority after you control the heart rate? Why are they in cardiac monitor? What are you monitoring for? So what are you monitoring for? Watching for? I can tell you, we're looking for why a narrow pulse pressure. Okay, we're looking for muffled heart sounds. Okay, we're looking for hypertension. We're looking for pulses paradoxical. Okay, those are the things we're looking for. And the last one, JVD. Does that give you a clue? So anybody who get ascending aortic dissection, your priority is this. After you control with the beta blocker, priority is that. And what is that? Cardiac tamponade, right? That's a priority. Anybody that go into dissection. So luckily, we were able to we fixed this patient, we controlled the blood pressure, there was no cardiac tamponade, we repair everything, and then the patient did well without any problem. Right? No problem. She came back when she's a year later, right? 1 year later, with symptoms, the following symptoms in 2 weeks. What do you think is wrong with this patient now? She has Marfan syndrome. She developed aortic dissection. We repair it. We look for cardiac tamponade. There's not. A year later, she has leg edema, JVD, hepatosplenomegaly, ascites, facial edema, and weight gain over 2. What do you think is that? What are those signs? You can tell what I'm trying to do. You can figure out as the case progresses. I'm taking you around. So what are those signs? And somebody said, well, what about what? Pink through the sputum and low urine output, hypotension, crackles in the lung base. He said, well, I don't know, but what do you see? What is the difference between this and that, this one and that one? What do you think? So it's 1 year later, this is what she came in with, right? And you can tell she's in heart failure. This is a right-sided heart failure. And this is the left-sided heart failure, right? And these are all forward flow problem. And this is the conjunction on the left side, right? So those are the things that I want you to pay attention. So the doctor said, well, let me see what is indicated. So indicated or not indicated. give them spironolactone, you can give them Myronol based on its symptoms. It's either this one or this, both of them are the same. So, what is your treatment? Ethacrenic acid, nifedipine, hydrochlorothiazide, spironolactone, Myronol. Is it indicated? You just have to tell me if it's okay to give it to the patient. What do you think? Ethacrenic acid is a loop diuretic, so it's indicated. Nifedipine is a calcium channel blocker. The vasodilating, they are also indicating. Hydrochlorothiazide is a diuretic, right? Spironolactone is a potassium sparing, is indicated. Myronol is a nitrate, so it's also indicated. All these things can be used in heart failure, and it can be used to treat this patient on both sides, right? All of them are indicated for management of heart failure, right? So they are all indicated. So we treat the heart failure, we did everything. Of course, when she's going home, you tell her if you're on spironolactone, you should avoid what? Too much banana. This increases your potassium, right? You should avoid it. If you're on Myronol, you should avoid any other nitrate, right? Calcium channel blocker and nifedipine, you should expect your face is going to flush. You're going to have leg edema, or it's an expected finding. They are not a problem. Of course, you got to avoid grapefruit juice, right? Those are the things. And if you're on hydrochlorothiazide, watch for hypergluc, right? Those are the side effects of that. Glucose, uric acid, calcium, and lipid problem. So don't worry. It's a sulfur drug, so worry about photosensitivity and Stevie-Johnson syndrome. So all of these are calcium channel blockers. They are used for heart failure. Calcium channel blocker can be used for heart failure. It decreases how much fluid go to the heart. So they are all indicated as much as possible. Now, this patient came in 6 months later, 6 months in the emergency room, right? What did she complain about? Right? Chest pain. Again, that when you check, there's ST elevation. ST elevation, right? And they check the troponin, it's also elevated. What is your diagnosis? What is my diagnosis? Myocardial infarction. Okay. So this patient had an MI, right? MI. This is within 5 hours. Okay. And then we decided we're going to do cardiac catheterization. Okay. Cardiac cath, basically. We're going to do cardiac cath. Right. We did a cardiac cath. What are the things you worry about? What do you think you should know about this patient if he's going to get a cardiac cath? So if he's going to get a cardiac cath, there's certain things you have to worry about. We're going to give the patient contrast. If she's on metformin, you got to worry about it. You got to explain the procedure to them, and then how long it's going to take and what kind of complications they're going to get. So you did a cardiac cath, and you found stenosis, which they stented, right? They put a stent in, and they put the patient on anticoagulation. So the patient is on Enoxaparin. What kind of teaching do you provide for this patient? Avoid green leafy vegetables, avoid vitamin K, electric shaver, avoid NSAID, LS bracelet, Bristol toothbrush, use Z-track technique. Right? There's a lot of traps here, right? Enoxaparin is heparin. When you're on heparin, there's no diet issue. You should not even worry about diet. So this one is wrong. Vitamin K is wrong. Electric shaver, yeah, bleeding, right? NSAID, yes. LS bracelet, so that everybody will know about it. Bristol toothbrush, right? How about this? Z-track technique. Z-track technique It's for IM medication. This is a sub-Q, therefore it does not go. You see, I take you to fundamentals right there, right? Good. Now, put this patient on Coumadin. So, yes, first, perfect, valve, INR. What do you want it to be on Coumadin? So the best way is 2.5 and 3.5 is the best number. Right. 2.5 and 3.5 is the best number. What do you want the PTT to be if the client is on enoxaparin? So, key concept. You don't need to check PTT. Okay? If you're on enoxaparin, you don't need to check it. You don't need to monitor it. So, there's no need. So, that means you don't need, this is what they ask you, no lab draw for enoxaparin. Okay? Key concept. Don't forget that. No lab draw for enoxaparin when you're on that medication. Okay? That's something you should know. And so, patient went to the dentist and he has a dental procedure. 2 days later, what do we have? We have fever. Okay. We have fever and we have a heart murmur. And then arterial. What is your diagnosis? Okay. And how should we have prevented this? So patient has endocarditis. It's from the dental procedure that is seeding. We should have given this patient antibiotic prophylaxisly if you have prosthetic bags to do that. So we have bacterial endocarditis. What do you expect to see in bacterial endocarditis? We know the patient has bacterial endocarditis because they have a dental problem, but we examine the patient. What should we expect? Content, I want you to master your cardiology. You see what I've done to you. Fever is unexpected finding, right? You see also note, if you want to know, you should check adapter anchors, but the keyword is from Jane. This is how you can remember endocarditis, right? Oslo note is expected. Rod spot is expected. They get a heart murmur, they get Janeway lesion, they get anemia, and they get a new blood problem. If they have weakness, okay, or slur speech, that means we don't expect that. That's bad. That means they have complication related to that. They have stroke. So watch for that. Stroke is a bad problem because the vegetation has embolized to every place. This is our expected finding related to endocarditis, fever, Oslo, no, rotospot, murmur, Janeway lesion, anemia, and new birth. Those are all expected, and I call it from Jane, right? So that's all the things you will see from that particular patient. Luckily, we were able to treat with what? A long-term antibiotic. So the treatment is a long-term antibiotic. Okay. Unfortunately, 3 months, patient came in with what? Chest pain again. Chest pain again. But this pain is relieved by leaning forward. And when you check the EKG, it shows diffuse ST elevation. What is your diagnosis? So somebody said, what is your diagnosis? So we have pericarditis, and we treat with what? Colchicine, right? We treat with colchicine as much as possible, right? Colchicine, because it's an inflammatory process. So we were able to solve it and treat it by 2 days in the ICU. Um, the nurse saw, listen, and it felt like these features. Remember, she has pericarditis. And so what should you worry about? What should you worry about? I have pericarditis. What is the key aspect of it? Marfan is not good. CVP of 7 is normal. This blood pressure is worrisome. This is what we call narrow pulse pressure, right? 140 over 110. There's no pulse pressure. Small crackles in lung base is not that. Saturation is not that. These two is consistent with tamponade. So anybody with pericarditis, you worry about them developing constrictive pericarditis. So that's what you worry about, constrictive pericarditis. So pay attention to that whenever they ask you, that's what you worry about. This patient is developing constrictive pericarditis. And so we did paracentesis, there's no fluid. We treat with the colchicine and help with that. She presented a year later to a primary care doctor. She said, oh, when I walk 1 mile, I start having calf pain, right? I have calf pain. Then it goes away when I rest, right? It goes away when after rest, right? So, and so the nurse is trying to figure out whether this is arterial problem or a venous problem, you think? What do you think? Which one the leg is going to be cold? Which one the leg is going to be warm? Brownie pigmentation, leg edema, beefy red ulcer, dependent rubor, color and elevation, pain with dependent position, and toe gangrene. What do you think? So, how do you distinguish between them? Trying to figure out, she said, help me out, doctor. You got to help me out. The new graduate say, hey, I don't know the difference between this arterial and the venous problem. How would I know? Just help me out. So when the leg is cold, it's arterial disease. Think of arterial problem as a dependent flow, blood flow in the dependent position. Therefore, if you have atherosclerosis, blood is going to decrease in terms of flow. And so the leg doesn't get a lot of blood. So the leg get cold. In venous disease, you have too much blood, so the leg get warm. If you have too much blood, the iron leak, hemoglobin, hemosiderin deposition, so you look browny here. That's how you get edema. That's why your ulcers are red, because you have too much blood in there, right? If you put your leg down, it get red, it's because you have pulmonary PAD. If you elevate it and it look white, because we have PAD. If you pain when you're in a dependent position, your leg is down in the PAD, they need their leg to be in the dependent position, so they're not going to have pain. The only person who's going to have pain is PVD. And who has toe ganglion? Blood flow to your toe is decrease in PAD. So they get a toe ganglion. So this is that. You see, I've taken you everywhere, right? And so this is what happened. And that's the difference between PAD and that. Unfortunately, this patient came to the emergency room with shortness of breath, right? And we want to figure out if the patient has tamponade or tension pneumothorax, right? Or pneumothorax, right? Tension pneumothorax. This is tamponade. Because NG and go, this is what you're going to get. Like a bunch of questions I heard NGN thinking, test taking strategy. You see, I did not give you a big lecture on tamponade or tension in pneumothorax, but all this thing is the buzzword. If you feel this, you know everything about tension in pneumothorax, right? So, what's the difference between them? What is the difference? What is the difference between a tension pneumothorax and a tamponade? Keyword, right? Tension, think about it. Pneumothorax has something to do with breath sound. Tamponade has something to do with your heart. So if you see the key fact, I hear left decreased breath sound on the left side, wherever it's located, is tension. Muffled heart sound, it has to be there. Both of them are going to cause JBD. Both of them are going to cause hypertension. You don't think that's why your board will give you that because they look the same. Narrow pulse pressure is tamponade. Hyperresonance is tension pneumothorax. And tracheal deviation is tension pneumothorax. This is adapting class. I hope I've taken you somewhere you've never been before. Good luck. And like I said, if you want to join our review crash course, just email me. The email is adaptandclass@gmail.com. If you want to join our memberships, gold membership, and GN Gold, you'll see a bunch of these easy, straightforward questions. But this is me checking out. You guys have a good day.